Hello guys, welcome to our channel, thesurgerytimes. Myself, Dr. Aditya Prasad Padi. Follow us in Instagram, Telegram, Facebook, as well as in YouTube. Okay, so today's topic is Fourniers gangrene. So it is very important topic because it is life-threatening condition. Okay, patient came to you within 6 to 8 hours, landed in trouble. Okay, and also if delayed, then a high chances of mortality is there. Okay, so we will discuss regarding everything in this video. So like, share, comment, and follow us in Instagram, Telegram, Facebook, as well as in YouTube, the surgery times, and many more topics also there for upcoming. Okay, so the study is needed because first, if you are MBBS student, okay, then it is very important as a short note. If you are PG, doing PG now, then also for university exam, it is a very important question. Okay, in last 10 years question, it may come many times. Okay, if you are a NEET aspirant, then also clinical based question you can face from Fourniers gangrene. If you are non-medical also, for day-to-day life or as it is an emergency condition, you should know regarding this. So the topic is Fourniers gangrene. Okay, and many of you also know regarding this, but we'll collect the data from various articles as well as books and compile it here. So go through it, and it is very important. So let's start the topic. Okay. So what is the definition? So definition is it is a fulminant form, very important. Okay, of infective necrotizing fasciitis. Okay, so our doubt is it is occur in male, but no, it can also occur in female, but more common in male. Okay, and it is occur more common in older age group and immunocompromised patient like T2DM or HIV or corticosteroid. We will discuss regarding everything. Just in a gist, I like to tell you. Okay, so it is a fulminant form of infective necrotizing fasciitis. It can occur in the perineal, genital, or perianal. Okay, perineal, genital, or perianal region. Remember, it commonly affects men, but also can occur in women as well as children. Okay, this much is very important. It is the definition of um, Fourniers gangrene. So next is other names of Fournier gangrene. It is very important. Otherwise called as idiopathic gangrene of scrotum, streptococcal scrotal gangrene, perineal phlegmon, or spontaneous fulminant gangrene of scrotum. Okay, these are the other name of Fournier's gangrene. Now, the next thing is it can occur, most commonly occur in older patients. Okay, most commonly occur in older patient, and indolent course, limit, and less abrupt onset, and 95% of cases the source can be identified. So after identifying the source, we can start antibiotic, okay, and also surgical intervention, debridement. Okay, so by actively doing all these things, we can get over the disease. Otherwise, it is a very life-threatening condition. Okay, so infection most commonly arises from skin, urethra, or rectal region. Okay, nearby all those things, and it is associated with urethral obstruction like stricture or extravasation and instrumentation to be documented. So while taking history, you should keep focus on these things. Okay. Now etiology. Etiology mainly of three types. We will discuss one by one. One is urological, one is gynecological. Okay, one is area. So first is urogenital. Urogenital, you can see urethral stricture or calculi. So these are U. Okay, in order to remember easily. Then T, traumatic catheterization or TBT procedure. Now, indwelling catheter or insertion of penile prosthesis or intracavernosal cocaine injection. And mainly in some cases like erectile dysfunction or Peyronie's disease, these are using. So you remember all these cases, there is high chances of development of Fourniers gangrene. So you can see over here, just 1 minute. You can see over here U, T, and I. Okay, so remember like this. For mainly to attend one short note, you should elaborate all those things. Okay, hydrocele aspiration is important, and in also clinically you can see all these cases. Okay, delayed rupture of ileal new bladder and genital piercing. perineal trauma, prostatic biopsy, and vasectomy. Okay, and the second cause is anorectal. Okay, so anorectal is perineal abscess, hemorrhoidectomy, rectal biopsy, rectosigmoid malignancy, anal dilatation, appendicitis, diverticulitis. Okay, so you remember PRAD, PHRRAAD. So if you will go through this slide repeatedly, so you can know regarding the etiology. It is very easy also, because anorectal means in those areas you should imagine abscess or hemorrhoidectomy, rectal biopsy, malignancy, dilatation, appendicitis, diverticulitis. Now our third is gynecological. So though gynecological, it is very rare and mainly perianal or perineal. Okay, those reasons will be involved, as male genital is not there. It is gynecological conditions like septic abortion, episiotomy, coital injury, okay, genital mutilation, infected Bartholin gland, okay, all those things will cause the Fournier gangrene. So here you can see, if urethral obstruction is there like stricture, then infecting bacteria may pass through the box fascia of penis and spread along with dartos fascia of penis or scrotum, then collis fascia of perineum, or it may go towards the scarpa fascia of anterior abdominal wall. So three-way it can spread too. Okay, remember. Now next is our comorbid risk factors or predisposing factors in order to development of the Fournier's gangrene. That is, first is type 2 diabetes, HIV, alcohol. So main important is immunosuppression. So all things coming under immunosuppression are the comorbid or predisposing factors for Fournier gangrene, like type 2 diabetes, HIV, alcohol, chemotherapy, corticosteroid, chronic use, leukemia, liver disease, or debilitating illness. Okay, so you remember this much. Now our next is there is typical foul odor, okay, associated with this condition. Then you should think of anaerobic bacteria. Okay, now if you will take the culture, own culture, then you will found multiple organisms. Okay, anaerobic as well as aerobic organisms you should found in the culture. Okay, so most preferable is tissue culture, remember. Now it may compromise of facultative organisms like E. coli, Klebsiella, Enterococci with anaerobes like Bacteroid, Fusobacterium, Clostridium, etc. Okay. Now, so what is the pathogenesis? Pathogenesis already we have discussed regarding the bacteria involved in this. Okay. So whenever there is suppurative bacterial infection, okay, it will result in microthrombosis of the small subcutaneous vessels, okay, which develop the gangrene of the overlying skin. This is the general mechanism of the gangrene. Okay, here also the same, but it occurs nearby the perineum, perianal, scrotal region. Okay, now the synergistic activity of aerobes and anaerobes, they can produce various exotoxin or enzymes. Okay, those helps in tissue destruction and spread of infection. So what are the enzymes? Like collagenase, heparinase, hyaluronase, etc. Okay, so as mixed bacteria, aerobic plus anaerobic, they can produce exotoxin enzyme, then tissue destruction and spread of infection. This is the sequence. Okay, now, so aerobes can induce platelet aggregation and complement fixation, whereas anaerobes produce heparinase and collagenase, which further causes microvascular thrombosis and dermal necrosis. Okay, so these are different. You should remember aerobes how they are doing, anaerobes how they are causing the Fournier gangrene. And if there is also phagocytic activity impairs the necrotic tissue and further spread of infection, it will help. Okay, so all those activities, this is pathogenesis. And regarding the bacteria, aerobe and anaerobe examples we have already discussed. Now clinical presentation, as you can see in the diagram, 65-year male came with scrotal edema. Okay, it is of 1 day history. Okay, there is swelling, tenderness, as well as in fever history was there. Okay, so you can see a patch over the scrotum. Okay, this you can say as initial presentation. Okay, all the features of inflammation will be there. Okay, color, rubor, tumor. Okay, all those in the pathology. Along with that, there is signs like black patches over the scrotum will be there. These are the initial, because in advanced stages, the skin may not be there over the scrotum. So let's discuss. So history again. Recent perineal trauma instrumentation already we have discussed. Okay, so there may be rectal source or dermal source. Okay, so rectal source like pain, rectal bleeding, or anal fissure or surgery, if anything is there, or history of anal fissure, then that is a rectal source. Dermal source suggestive of history of acute or chronic infectious scrotum like hidradenitis suppurativa or balanitis. Okay, so you should think of rectal source or dermal source. Accordingly, you should take the history and examine the patient. Okay, so infection commonly starts as a cellulitis in the adjacent to portal of entry. Okay, portal of entry, either urethra, perianal region, perineal region, like that. Okay, and as we have seen, it is swollen, erythematous, tender. Okay, and gradually pain will be prominent along with fever and systemic toxicity. Okay, now swelling and crepitus of the scrotum quickly increases and dark purple area over the screen and extensive gangrene. So here the subcutaneous crepitus. Okay, subcutaneous crepitus you will found, means when you will palpate the scrotum, there is crepitus you can feel. Okay, this is the main feature in case of Fournier's gangrene. If abdominal wall is involved along with immunocompromise like diabetes or anything, then it very rapidly it will develop. So it may associated with dysuria, means there is painful micturition. Okay, urethral discharge or obstructed voiding symptoms also will be there. So if there is altered mental status, tachypnea, tachycardia, and temperature of two varieties, less than 101 degree Fahrenheit, more than 101, or less than 96, more than 101 or less than 96 degree Fahrenheit. Okay, this suggestive of gram negative sepsis. Okay, so extreme cold or extreme heat, like this you should remember. Got it? Now next is differential diagnosis. So differential diagnosis also you should know for the exam theory papers. Okay, it may be cellulitis, already we have discussed. Then 3S, strangulated hernia, abscess, scrotal abscess, and streptococcal necrotizing fasciitis, gonococcal balanitis, edema, or herpes simplex infection, pyoderma gangrenosum, polyarteritis nodosa, PAN. Okay, allergic vasculitis or necrolytic migratory erythema. So you can see over here differential diagnosis. There are there are around 11, 10, 11 are there. So you should remember it is C, 3S. I have arranged sequentially. It will be helpful for easy remembrance. Okay, so go through it repeatedly so that you will get a good score in theory also. Okay. Now, migratory erythema, ecthyma gangrenosum, vascular occlusion syndrome, and warfarin necrosis. Then lab diagnosis, radiological findings. So, as it is infective, okay, as well as there is some changes in the erythrocytes. Okay, we have already discussed in the subcutaneous level, it will occlusion will be there, so gangrene will occur. So, you should see for hemoglobin. Here, anemia usually will be there. Anemia will be there. Okay. So, secondary to decreasing functioning erythrocyte mass caused by thrombosis or ecchymosis with decreased production of and decreases due to sepsis. So, remember, overall, there should be anemia. Okay. Along with that, there is serum creatine level will be increased. Okay, there is decreased sodium and decreased calcium. So three things: decreased hemoglobin, anemia. Okay, decreased sodium, decreased calcium, increased serum creatinine, because there is renal function test will be deranged. So hypocalcemia why occurs? Because secondary to bacterial lipase destroys the triglycerides and releases the free fatty acids, and those that chelate with calcium and in its ionized form. Okay, that's why the calcium, due to calcium chelation, there is hypocalcemia occurs. So you should remember these four things. It is important in clinical point of view also. During treating a patient, you should look for hemoglobin, sodium, calcium, and triglycerides mainly. Potassium also preferable. Now, subcutaneous gas or crepitus is an early finding. Okay, plain film of abdomen for identifying air, but usually only clinically. No X-ray is required. Clinically, we can see the crepitus and scrotal ultrasonography. So, biopsy of the base of the ulcer, you will find superficially intact epidermis with dermal necrosis, vascular thrombosis, and polymorphonuclear invasion. Okay, now it is important. Frozen section within 21 hours after the onset of symptom in order to confirm the diagnosis and early treatment. Okay, frozen section within 21 hours of onset of the symptom, remember. Now, after everything we discussed the definition, okay, quickly revise definition, then etiology, okay, then predisposing factor, then lab diagnosis, clinical feature, then lab diagnosis. Now we will, the last part is management. Okay, we will discuss now. So management, early and prompt management is required because very rapidly the infection spread to, suppose this is the lower abdomen. Okay, this is the penile region, penils or scrotum. So from here, penis will be involved, scrotum, penis, then it may spread towards the abdomen also in the scalpa fascia as we have discussed. So prompt treatment should be required. Along with that, patient may go into shock also. Okay, so as there is the features are same like pain, edema, erythema. So we cannot differentiate between cellulitis and necrotic fasciitis. Okay, so mark systemic toxicity means it should be very alert for the clinician. You should remember this. So how will you treat the case? So first is IV hydration and antimicrobial therapy, very important. Then surgical debridement. So one, hydration, antibiotic, surgery. Okay, debridement. So what antimicrobial regimen you will prefer? Antimicrobial agents like beta-lactamase inhibitor. Okay, that is the broad spectrum antibiotic. So remember always piperacillin tazobactam will be used, and mainly if pseudomonas is suspected. So pseudomonas clinically you can identify as green. The wound will become green. Okay, so next is our ampicillin can be also used with sulbactam, and always remember if in clinically we are using piperacillin tazobactam with metronidazole. So metronidazole dose will be 500 mg IV TID thrice daily. Okay, if it will given in the tablet form, then 400 mg TID. Okay, but in hospital setup and as the patient is admitted, injectable will be preferable, piperacillin tazobactam and metronidazole mainly. Okay, and also along with the biopsy culture sensitivity. Okay, culture sensitivity you can vary the, if it is resistant then others should be given like meropenem, carbapenem, all those things. Now immediate debridement is required. So after hydration, antibiotic, now surgery, third part as we have discussed. Okay, so extensive incision will be made through skin and subcutaneous tissue and going beyond the areas involvement until the normal fascia is found. So extensive incision is required. This is the very important part. Okay. Now necrotic fat fascia excision should be done, and the main thing is wound should be left open. So surgery is done. Now small wound or extensive wound. Small wound sometime we can close, but ideally it should not be closed in same time. It should be after 24 to 48 hours. A second look should be done, and after that closure of the wound should be indicated. This is the main, okay, important part. Now, very important is orchidectomy should not be done. In need point of view also, it is very important. Orchidectomy should never require, as testes have their own blood supply. Okay, independent of facial or cutaneous circulation to scrotum. So this is scrotum, testis. So we are dividing the scrotum part, but the testicular blood vessel, testicular artery is preserving. So there is no need for orchidectomy in case of Fournier's gangrene. Very important. Okay, it is need point of view also, it is important. Now next part is in case of extensive Fournier's gangrene. Okay, suprapubic diversion may be required if in case of urethral trauma or extravasation if suspected. Okay, colostomy if colonic or rectal perforation is there. And one more thing nowadays coming is hyperbaric oxygen therapy, but it helps in wound healing. Okay, and decreases the gangrenous spread also. But along with this, antibiotic as well as surgery is required. After that, only hyperbaric oxygen, because only if you are giving hyperbaric oxygen is no use. So along with this, you can use. So it is found out to be helpful nowadays. Okay, so important. Now, after wound healing, this reconstruction. So because the if it is in the advanced stage of Fournier's gangrene, we can totally resect the scrotum. The testis will be outside. Okay, so it may happen. So after wound healing, the reconstruction should be done by using myocutaneous flap for cosmetic result. So we can keep into the thigh or any covering myocutaneous flap over the testis. We should give later. So outcome, mortality rate varies from 7 to 75%. See how mortality it is. Okay, so and higher mortality in case of immunocompromised, diabetic, hypertensive, alcoholics, all those things. Okay, so hence prompt diagnosis and treatment is must. It is a true urologic emergency. Okay, so early recognition and aggressive treatment of antimicrobial agent, surgical debridement in order to reduce the morbidity mortality is required. So always remember, if a Fournier gangrene patient will come, in general I am telling, in emergency or casualty, first take the proper history. Okay, then clinical examination, increase in temperature above the scrotum, tender, okay, and swelling, any skin change. Okay, this is the main part. After that, you can suspecting of orchitis or epididyma orchitis or torsion testis or Fournier gangrene. So if as we have discussed, old age, male, old age, immunocompromised, then you can suspect of Fournier's gangrene. So clinically you can see crepitosis present or any of these symptoms present. After that you can go for USG and blood investigations as we have discussed. Okay, so after you will confirm as it is a Fournier gangrene, then prompt evaluation and treatment, hydration, antibiotic, piperacillin tazobactam, along with metronidazole we should start, and along with surgical debridement. And most important is, in one set you should not go for the closure. First open the wound, debride adequately beyond the excision. After that, after 24 to 48 hours, you close the wound. This is the way how to treat. Along with that, hyperbaric oxygen, if it is available, you can provide also. So this is how the Fournier gangrene is very important, and it is a very important clinical practice also. So thank you all, and see you next video. So kindly subscribe our channel and like, comment and share. Any doubt, then comment in the box and follow us